Welcome back to Conversations with AcroPsych, where we aim to create educational and inspiring dialogue around psychiatry and addiction. I'm your host, Dr. Matt Campbell, and today I'm joined by an exciting guest, someone who's both my brother and an incredible physician, Dr. Jon Violetta. He spent 4 years at Carroll College in Helena, Montana, 4 years in Creighton Med School over in Omaha, Nebraska, and then 5 years doing double board, 2 different specialties in peds and emergency medicine. He now recently has some exciting life changes, got married, has a baby on the way, moved and starting his career as a emergency room physician in Spokane, Washington. Jon, welcome to the podcast.
Thanks for having me. Means a lot to me.
Yeah, the last brother, but the first guest, which is
Best for
exciting.
last is what Boot used to say to me. The ultimate
That's what I hear,
Campbell.
The ultimate Campbell, so don't outshine me too much. To get started, do you mind talking to us a little bit about what it means to be double board certified and specialized and what drove you to take on that many years of training?
So everybody goes through the same med school and then you apply into residency, and that's where people kind of tear off and do their different thing. There's like general surgery, internal medicine, pediatrics, emergency medicine, orthopedic surgery. And so there are these sister residencies. There's a little bit of philosophy changes that are different in each training program. So I think there's a really good benefit of learning from kind of a different system. I wanted to do general emergency medicine, pediatric emergency medicine, as well as outpatient pediatrics. That was kind of my original goal. As of right now, I've only done adult emergency medicine and mainly pediatric emergency medicine, but I think at some point I may utilize some of those other hats for different opportunities in the future if they present themselves.
Really set you up with a lot of opportunities for your career.
A lot of opportunities. I think a lot of us in our family are that way of, being a generalist is really difficult in healthcare. I think the benefit is that you can make it into what you want at different parts, and what you may want in your 30s may be different than your 40s and your 50s and 60s if you're lucky enough to have a career like that.
What do you think you want in your 30s?
To be out of debt. Pediatric emergency medicine is definitely the right fit for me at this moment. We'll have to kind of see how things go. Working nights and days and evenings and switching, not having any sort of regular sleep cycle affects me more now than it did 10 years ago.
Yeah, that's a good point. What's your schedule that you've been on right now? Are we catching you off of nights, or where have you been on?
Yeah, a couple days off of nights. So now is when you're finally back to a somewhat normal schedule. You go to bed at a regular time. I see my wife a little bit more regularly, and we're eating breakfast at the same time and coffee at the same time, and those kind of things are finally lining up. I've got another 2 days off. I'm painting in all of my free time, so got my job on the side. Yeah.
Yeah, I hear you're getting a room ready.
Getting a room ready. Yeah, I got a exciting little girl coming in July, so getting
Congrats.
the room all ready, and yeah, appreciate it. It's been an exciting change for a first, and it's a big opportunity for growth. A lot of learning, a lot of humility coming at you.
Well, I imagine all of that emergency room and pediatric emergency room will have you cool as a cucumber as you have to navigate all of that stuff.
Yeah, hopefully. It's a little different when it's your own. There's something psychologically that just twists just a little bit. It correlates.
You feeling a little anxious before you get one?
I think there's some part of your rational brain that just gets turned off when you're looking at your kid, and you just are, especially with Google, you can look up all sorts of stuff and learn about all these horrible things. And, you experience people who have had really terrible things happen. It's hard to turn that off and be just in the moment.
I want to hear you talk a little bit about going through all this extra training. If you can't give me maybe a story or what it was like going through that much training, especially during the pandemic. I imagine being there in the front lines, the emergency room, what it was like going through that amount of intense medical training for you.
It was rough. Residency is, I think the honest answer is residency is just hell. It's difficult. It's kind of like a necessary evil is how I view it, because you're also training the ultimate job, which, to make life and death decisions about somebody else in their life. That is such high stakes. You need to be so well trained in order to do that. And you're never, in my opinion, you're never good enough, right? Nobody's good enough to really do that. So what's the most that you can learn, the skills that you can learn so that you are the best that you can be, which is ultimately the goal every day, is tough. So you're switching nights and days, and the stress and the learning. The pandemic was rough, and I think my training was maybe especially hard because pediatrics and emergency medicine are very different philosophical field. Like pediatrics is warm and cuddly, and the mentors kind of hold on to you a little bit more. They're a little bit more of like your hypervigilant parent who doesn't let you cross the street because you're going to scuff your pants. Then you go to the emergency medicine side, who is totally the laissez-faire. People have been doing this for thousands of years. You'll be all right. You'll grow up, and much more hands off. And so you would be doing something with critical care one day. You have to think of all the different physiology and all these different medications. You're doing all these procedures that are so specific and so difficult. And the next day you're in the outpatient pediatrics clinic and you can't apply something to a kid's teeth because the mentor needs to be there and do it for you. And you're like, I just that was difficult. And then the pandemic was just the icing on the cake. People were losing their loved ones and everyone was scared and we didn't really know what we were doing. Learning on the fly, which is difficult for everybody. There's a lot of uneasiness and there's anxiety on our side and there's anxiety on their side. And you're trying to do your best and you're working your butt off. But you really, you don't have objective data to rely on for the last 100 years. It's like, well, there's a case report of this maybe works and this doesn't. And who do you trust and who do you not trust? And then, misinformation and different things that became a problem. It was tough. That was
It
not
was.
not an experience I hope for in my career again.
Remember, I was kind of finishing residency and training during that time. And being a psychiatrist, we were definitely a different role during that time. I at least had some exposure to the medical floors. I think what stood out to me is it was such a stark time of realizing how slow medicine moves, and how
Yeah.
long it takes us to really accumulate information and understand how to treat things, what the risks are. And the accumulation of that study and information is such a slow process. You throw in this new disease, it's such a chaotic thing to be right in the middle of it as you're trying to juggle all that new information that's changing daily there.
Uh-huh. Yeah, very, very well put. That's exactly how it felt. It does take a really long time, and there's a reason it takes a long time. I think the flip side is then there were things that we thought would maybe be useful, and it wasn't. But as time kind of shows all maybe. But yeah, definitely a tough time.
Well, as you've now jumped in, you've finished the training, you've started working, what's your favorite part about the job that you've worked so hard to end up with?
There's many parts that I love about my job. I think a common thing people say to you when you're training is what gets you out of bed Friday night at 3 o'clock in the morning. You're sick. Your kids are sick. You haven't been sleeping well. Who is the patient or what is the thing, the phone call that you get that gets you out of bed and ready to go help somebody? For me, it's parents. That look of uncertainty in a parent's eyes when they're really worried about a kid, and being somebody who gets to be there for them, hopefully take great care of their child and treat them as they would want to be treated, I think it's very fulfilling. It's difficult, it's stressful, it's frustrating, but I also think it's extremely fulfilling that I have a job I really care about. I have people I really care about. It doesn't make it easy, but I think the lack of it being easy is also what makes it great.
I imagine it's pretty powerful, I mean, to be entrusted with the thing most valuable and precious to these people, and when they're most frightened, it sounds like it's pretty powerful when things go well and you get to experience that with them. Switching gears a little bit, how psychiatry and addiction comes up, in the emergency room. I'm no longer working in an emergency room, so it feels a little bit distant from me. I think
Yeah,
that
you left us.
I s I felt pretty clear that that was not the place for me. When you're thinking of all of the challenges that come up in the emergency room, I know psychiatry and addiction is a big one. What's the actual experience like for you being on the front lines of that, of actually delivering the care and working as a emergency room doc?
It's difficult, I think is the easiest answer. Of I think frustrating, not because of the patients or their situation or what's bringing them in. I think frustrating of in healthcare we like our black and white medicine, this is the answer, this is not the answer. I think that's generally how we frame our minds. We're very objective. There's a little bit more kind of feeling subjective nature that's in here. And then just the resources and the stress and the frustration of family members, loved ones, who you name it, seeing someone you care about make decisions that are hurting them, and there's not really any much you can do about it. And that's what makes it so frustrating is somebody has a substance use disorder and they break their leg. Sure, we can fix that, but that's really not the amount of alcohol and drug use that they're partaking in that led to them breaking their leg is really the core foundational problem. And what are we doing to directly face that? I think can be really, really difficult. And it's a large portion of my job, and it's becoming more and more in the adolescent population and younger ages. And it's a huge portion of our job, and there's kids boarding in the emergency room, and it's just difficult on everybody.
Can you talk to us a little bit more about what boarding in the emergency room, what that is for people who don't know?
Yeah, boarding boarding is you're kind of stuck in a place waiting to go where you're ultimately going to go. So one of the core parts of emergency medicine is figuring out where people belong. Can you stay outpatient, which is, you go home and you see people in clinics and, maybe some resources come to your house. That's outpatient. Then there's inpatient, which is within the hospital. And for psychiatric services, that's inpatient in a psychiatric hospital. Skilled nursing facilities, inpatient rehabs, there's kind of some middle ground areas. And then ultimately, other levels within the hospital. So I'm kind of the filter, if you will. Where do you end up? Do you go home? Do you go in the hospital? Do you end up in one of these other resources? So for a lot of people, especially with mental health concerns, there's where do you go? All these places are very full. So when people need to go inpatient, they don't have anywhere to go. Then they're in the emergency room, which is a safe place. They end up using an emergency room bed for multiple days. I mean, I've had kids weeks to months. We have a lot of resources so we can ultimately take care of them, but we've become the answer for so many people. I'm happy to help and I want to be a part of solutions, but sometimes people just take the easy answer, which is, oh, the emergency room can do it. Oh, the emergency room can do it. And it's like, well, there's only so many of us there. And I think it leads to a lot of frustration from providers towards mental health patients. It's not really that they're angry at those patients, but the situation, because now you got that child or that person is taking up a room, and that's a room that could be used for resuscitation for another sick kid, which is typically what we're envisioning when we go into our job. And there's people who are out in the lobby and waiting for 6 hours who are angry at us, and there's just no space to see them.
It's kind of like you guys have come up with the plan, you stabilized things, you're ready to move them to the next place, but that place isn't ready to receive them.
Correct.
The It builds kind of a backlog in the emergency room where you have less space in addition to all the acute new stuff that's coming in before they move.
Yeah. And then emergency medicine providers,
You like to keep moving.
we like to keep moving. Well, that's how we view our job. Our job is to see people, treat them, and get them to where they need to go. Getting handoff on patients is such a cultural frustration. I'm not an inpatient doctor. Don't tell me about someone who's been here for 12 hours. Like they need to be where they need to be. If they still need to be seen, they need to go to inpatient. Triage runs our whole system. If someone sick comes in, you drop everything, and that's where you are. So it's very difficult to manage both of those things at the same time.
So I would imagine then for you, because you've worked at a couple different hospitals, you're probably seeing where the psychiatry or addiction goes very smoothly and people move on well and they seem to be connected to the right resource. And then you see times where it's probably not going so well. Can you talk
Yeah.
me through like what kind of ways you've seen it where it's going well versus more of a challenge to get them to the right spot?
Yeah, I think in Spokane we have a pretty good system. Generally, there's more resources. And I think my greatest resource personally is my time, especially if I'm working for a 9-hour shift. There's only so much I can do throughout that time. And I need help, right? And I think this is something doctors don't like to say, but we need people outside of ourselves. We are not the be all end all. To do my job well, I need good nurses, I need good techs, I need good respiratory therapists, I need good social workers, I need good mental health specialists, I need psychiatrists, I need surgeons. Like all of that, we are so connected throughout this process that when it doesn't go well, it's usually the doctors kind of solely relied on. So they're therapists who are helping us, they're social workers who are helping us. They are kind of different, mental health specialists. And I think that's more of what we have where I currently work. It just makes things go smoother because they know the resources within the city so much better than I will ever know them. And then sometimes they even know these kids because they work in other places outside of the emergency room. They walk in the door and say, hey, so and so, how are you? It's like there's a relationship with the family. And I think that is so beneficial to those families, and it makes it go smoother because they know them from a year ago. They know them from past interactions they've had. They know, hey, you were doing really well 3 years ago, and like, what happened? Like I think that relationship is so crucial to those moments. I think when especially a kid can relate to somebody who's talking them through their problems, I think that is just like it hits and sticks so much better. And I think that's probably your challenge as a psychiatrist is relating to people enough, but then also keeping yourself composed and safe.
Makes me think of the most commonly repeated thing that I've seen that predicts good outcomes in any area of psychiatry and addiction seems to be the relationship. And so being able to build a good therapeutic alliance is just incredibly impactful. That's not exactly the nature of the emergency room isn't for building relationships, isn't like the way that it's designed. When you talk about someone who comes in with an overdose, someone who comes in suicidal or in a psychiatric crisis, that's what they need is relationship and hope and connected to the right resources. And it's hard to build those kind of things. It's hard to set that up in a place that's really emergency. It's talking about crises and putting out so many medical challenges. And so for you, what would your role be typically? Are you dealing with someone who's now had an overdose and clearing them medically? Are you dealing with people coming in intoxicated, withdrawal? Like what's the kind of work that you're seeing these challenges actually come into you?
Yeah, I think there's kind of a handful of, a lot of times it's people who are intoxicated or high or, whatever, and they've injured themselves. So trauma's probably up there. I mean, trauma's number one. Traumatic injury. They were driving while intoxicated. They were riding a scooter or a bike and got hit by a car, or, walked across the street and got hit by somebody, or got in a fight while they were intoxicated and now they're here with a fracture and whatever. So that's one of them. Overdoses is a very common one as well. I'm feeling so down on myself that I tried to kill myself. And thankfully they weren't successful. So then now we have a moment to intervene and make sure they're safe. So I'm medically clearing them to make sure what they took isn't too bad. And poison control is an amazing resource to help us with that, and stabilize them. And so, checking blood work and monitoring them for a certain amount of time, knowing that that medication has cleared. In worst case scenario, they did do something that could actually kill them. And then now it's providing an antidote and making sure they're stabilized, or, intervening in whatever way is necessary. I mean, all the way to people just feeling like, hey, I think if I stay home, I'm going to hurt myself and I don't want to do that. Therefore, I know this is a safe place, so I showed up here. And so there's kind of all within that spectrum.
I guess a lot of withdrawal, or did people not?
Withdrawal, yeah, sorry, we do see a lot of withdrawal. Trained in Arizona, and opiates they're there, but they weren't quite as prevalent as they are. It seems to be here in Washington. So it's a little bit more here, but yeah, definitely alcohol withdrawal is probably principal there. Yeah, and then all the different opiate withdrawal. And
I've been getting some questions about like kratom and high potency THC, like Delta 8 and some of those. Do you get a lot of those in Eastern Washington as well? People using those
yeah,
substances?
kratom I think used to be. I mean, I think it is definitely around, not as much as I think it was a few years ago, and maybe that's a little bit more regional. It sounds like some of my partners were like, "Oh yeah, kratom."
Seen it in New York.
Yeah. So I think it's different areas. And I mean, marijuana, this is like a huge problem with kids, but our generation is very comfortable with marijuana and it's legal. And I'm not necessarily wholly against it, but the problem is gummies look a lot like different gummies and kids get into them very frequently. Or kids will find cookies that they bring to school and then they eat a cookie at school and don't realize that it's covered in marijuana. And then they show up. And it's one of the harder cases, and you kind of can tell, but you're also like, this kid suddenly is really encephalopathic, like altered, confused, talking funny. I mean, your differential, which like all the different diseases you're worried about, is huge. And you're like, this could be something terrible. It could
Bad.
be, most commonly, it's an intoxicant, but I like being ahead of things. So like if something comes in, I don't know what it is. I like running at that, 100 miles an hour. Because the worst thing in emergency medicine is when you're like, oh, it's this. And then you go back in the room and you're like, oh man, they have worsened in front of us and we're missing something. And then you're playing catch up and it's just a not enjoyable experience and doesn't feel like good care and all of those difficulties. But yeah, marijuana is a very regular part of my job.
That's so you're having to differentiate all of these kind of things that are coming in, making sure people are medically safe. And then you're talking about the second layer of like, okay, well, how do we address the thing that's actually exacerbating or bringing them to this point? And that's where it's like, okay, well, where's the place that they can go once they're medically safe? Is there something that you see as like a fix that you would absolutely love if you had all the power, the resources, the tools to make a change in your early career that would really make a difference in how this problem gets addressed from the emergency room?
There's a few different thoughts I have on that. I think the first part I would make is it's well known in healthcare and in medicine that the most dangerous time for a patient is the like exchange of care. And so for us, that's like, okay, they're medically stable now. Now they need psychiatry. And like, where exactly is that line where my care ends and the next provider takes over and who's taking responsibility? If a psychiatrist comes down and consults, are they assuming care? Like where is that line and how much of that line exists? So I think that that's always an area that'll need improvement, and it's what we do can always be better. I mean, with that is like all sorts of different resources. We need a huge amount of resources going into mental health, especially like the kind of in between zones, especially so for our kids that are, developmentally disabled, nonverbal, aggressive. I mean, it's so much to ask on their parents, and they inevitably get overwhelmed because it's a 24/7 extremely difficult job. And then where do they stay? Where do they live? Who helps them? Who wants to help them? And resources are a huge problem in that population. And that's frequently the population that ends up in the emergency room the longest amount of time because they're big, they're strong, and they're really hard to kind of guide, as a human being when they're frustrated and banging their head on the wall, and it's really
That's some of
difficult.
the most heartbreaking things in medicine I've seen is the system and resources around people with developmental disabilities is so lacking and really,
Yeah,
really sad. Just
yeah.
something that I spent some years in before med school, and then seeing them sometimes like stuck in a inpatient psychiatric unit, kind of like you're talking about stuck in an emergency room, but where the resources may come from something different. And so for them to have a home when they're adults may be very hard to actually find because they can't go to a shelter, they can't go to the typical places.
Hmm.
And at least in New York, there's really no shelter, there's no place set up. And so it's very, very heartbreaking.
I think I think I would go more philosophical, and this is see
Now
what
we're
you think.
talking.
Hopefully, gosh, man, I'm gonna have to really. This might take a little while, but hopefully this makes sense. Am I allowed to talk about spirituality? Is that
Yeah,
is that
go
welcome
for
tonight?
it. Hey, you're the guest. You get to talk about whatever you want.
Oh, really? Okay. Let's see how this lands. So I have become Buddhist in my personal life, and it has been an incredible transformation for me personally. And one of the core philosophies that I think I derive a lot of benefit from is interdependentness, is kind of the word that people will say. I think for Christianity, from what I remember growing up, body of Christ would be kind of in the similar realm. Stay with me because it might take a little while, but the point is that you don't exist in a vacuum outside of everything else. So, who I am in this exact moment is so related to my parents and their relationship, how I was raised, siblings that I had, friendships that I had, illnesses that happened to me. All of those different portions that happen throughout my life have formed me into who I am at this moment. We'll kind of talk about dependent co-arising. Multiple things are kind of happening at the same time, and I'm changing and kind of evolving at kind of the same time as you. I think what I get from that is we all need each other. I am not this person that exists out in the world that doesn't need everybody else. We're all from the same thing within the same thing. And so I think seeing ourselves in each other and seeing how we need each other, it kind of gives meaning to everybody versus I think in our society very frequently make it seem like they're higher than us or they're lower than us, and we're here and we're kind of inflating our ego, and I have this job therefore my life has more meaning than everybody else's. And it's like, no, your life exists therefore it has meaning. I mean, that's too big for any hospital to incorporate, but I don't think too big for us to do in our personal lives or in our interactions with people. And I think that changes everything. Then when your friend is an addict and needs help, you can relate to them, you understand them, and you understand your need for them. It's not just like, oh, he's an addict now, I don't need him anymore. Or your employee is suicidal and needs help. You see them as a vital part of your team and not kind of like expendable. That would be my real core one.
I like the idea that you're getting at though, this idea of interdependence. Is that
Yeah.
the right
Inter
word?
interdependentness. I think it's a made up word. I mean, interbeing, interconnection is words that other people will say, but I'm a big on it. That's my one of my many major
Well, it
major
sounds a little bit like a shift in that I guess when people are at least a lot of times looking at their own desires and wants, it's kind of like what they can get from someone or how they can use someone or what they wish someone else's was doing, the way that they could control someone or get someone else to help them. But you're really shifting that completely and saying, I need you, you need me.
Yeah.
And everyone, we need Ashley, who's producing and running the show, and all of those ways we need that person. And it really changes the kind of relationship that we are then cultivating with that person.
Yeah, I think that's, as always, you express it in a much
Well,
more
no,
beautiful and
I'm trying to
eloquent.
hear.
Yeah, exactly. Well, and I think the other part, I mean, exists in me, right? We call it I, me, my. Like everybody has stuff that you're struggling with, right? It's like I got student loan bills, I got a mortgage, and having a kid, all the stress and frustrations that are going on with that. But that's all that absorbs in my mind. I see teenagers not infrequently, and it's 0 degrees outside, and they're sleeping in sleeping bags, with fires, and it's like Gosh, that is so far removed from what my teenage years were like. I think kind of shifting and cultivating, seeing them and not just like, oh, I'm going to give to them to make myself feel good. Like I really see them as a human being that has worth that I care about. That's really what I'm trying to get at. That kid who's developmentally delayed and who will never talk and is trach dependent, has a hole in their neck connected to a ventilator to breathe for them and a G tube going to their stomach to feed them. Do we see their life as a life that has worth? And therefore, we want to be a part of the solution. How much do we all help them and what resources help them? I think most of us get busy with our own lives, myself included, and you kind of, you forget. I think the flip side of that is it's really difficult in emergency medicine. You go in and you see everybody at their worst moment, worst day, and balancing that without like completely giving out your whole foundation, still going home and being at home and not bringing that home. It's a very difficult, I think, for everybody. As you open that up and start seeing these people and caring for them, it's tough.
Yeah. I like that you took it a little bit more philosophical than I was thinking. It's all those nights and sleep deprivation gets the
Yeah.
brain thinking, apparently.
Yeah, I think everybody's different. From age 22, I've had to witness some very difficult existence for other people's lives and answer to them when people look at you as the doctor like, hey, why is this happening? At least for me, that really stirs a lot of like very difficult questions that don't have simple answers. But I don't know, still require thinking, thought.
I feel like in the course of medical school, it wasn't really until going to residency and probably in a similar way, sitting with just intense suffering. And so much of healthcare is faced with intense suffering and dealing with and trying to alleviate suffering that we all have to reckon with that. And we all have to
Mhm.
figure that out in a way that hopefully inspires us to grow and do more and do better, as opposed to wall up or close off, which I think is it's definitely something that I've seen in myself and seen with colleagues as well.
Yeah.
So at such a young age, you're already delving through it.
I'm trying to cultivate the right seeds. And I think I've been very lucky that my significant other is healthcare related. It's different, but I think it naturally flows to have some of these difficult conversations. And she understands when I had a bad day at work and need to talk about that stuff. Yeah, it's been good. And then I get to be on podcasts and talk about it even more. Conversations you generally don't bring up around the dinner table, when you come home for the holidays. What do you think? I want to talk about our interdependent nature and
It's like,
how we all
"Hey, hey,
need each
Cougs are
other.
playing. Cougs are playing. Slow down. They might
I
win this game."
Yeah, yeah. It is funny.
Well, I want to get to the last question before we have to wrap things up. But if there's anything related to psychiatry or addiction that you see as underutilized, that you believe is something that should be known about or should grow in its use, its prevalence in the greater landscape of American healthcare.
Within healthcare, we're talking about. Do I gotta be philosophical again, or
You can grow outside of healthcare, but I think as it
specifically?
relates to people's health, I think would be.
I think, gosh, I think like what seeds are you cultivating? What things am I cultivating in our society and in my relationship and my friendship? So, a common thing that always got brought up, around family members who happen to be addicts, is are you the friend who's buying, the person who's an addict a beer and a shot at 12:30 as they drive home intoxicated? Are you the friend who's there for them when they're ready to turn things around, or helping cultivate some deep thought of, hey man, I just saw you put down 20 beers and you're driving intoxicated and you almost hit somebody. And sometimes you're a little bit of both. I've definitely been both. And I don't know. I really feel like I think a lot of people want to help, and I think a lot of people feel like they don't know what to do or how to help things. And I think like realizing your own potential, even in small ways, you don't drink or you don't do something, that's creating systems that I don't know. Now people are talking about it a little bit more. Or now certain non-alcoholic beers are more prevalent. Like you're inviting people to go on hikes and do stuff rather than, hey, let's just go meet at the bar.
It just made me think of a patient I had recently who so much of what I think would help this person is sober friends that they can go do sober activities with. And it's like, from a recovery standpoint, the medications I do, the therapy, any of those kind of pieces, they can be impactful. But if there were good, sober friends, the difference that it would make in own self-esteem, the own kind of journey that she would be on, I think would really, really just change her life in a way that I think would be very positive. What you're kind of talking about is the way in which we as individuals do truly have ripple effects that
Right.
can
Yeah.
make changes that, much past just the simple choice we're making in that moment.
Yeah, and I would add a little, like, be gentle to yourself at the end of that. It's like, I think it can make you go crazy of like, well, I'm not gonna drink, and I'm not gonna do this, and I'm not gonna do this. And
Mm.
it's like you can totally go way too far with it. Like, be gentle with yourself, recognize your limitations, and not every cause is your cause. It's the same thing of, mental health and is struggling and is depressed and having thoughts about harming themselves. Are you the friend who's created a warm environment where they can come to you and talk to you about like, hey, dude, like I have some really dark thoughts and I need to tell somebody because I'm going to do something if I don't tell somebody. Right. So you've cultivated that relationship. They know that you are there for them and you actually care about them. Or are you the friend who's kind of at a convenience, you'll be around them, but you don't really care about them? That's kind of what I mean. That cultivation ultimately makes a huge difference in people's lives. I can think of friends I would call at the drop of a hat if I had something bad. And that's, I think, a true friendship. But that's been kind of a seed that's been cultivated by them. And I'm so thankful that they have.
I think as you're saying it, I'm just kind of like hearing you and thought the general surgeon, did he make some sort of like announcement of a loneliness epidemic? I feel like there's some sort of thing that was stated about a loneliness epidemic from a pretty high ranking healthcare official. And there's AI coming out, and there's like all of these ways in which our lives are more and more disconnected from relationships with people.
Hmm.
And so much of what you've been talking about today is how we cultivate that as such a powerful piece to addiction psychiatry, healthcare at large, and how valuable those relationships are. I think it's very wise, very interesting take on all of this.
I hope it's wise. Yeah.
Can I ask you what you think about how the incentives around medicine are fairly reductionist? And so it's kind of like you need this ingredient, you just need this medication.
Yeah.
And I was having a conversation with Ashley at some point about kind of placebo and some studies in psychiatry where the really good psychiatrist, they were more effective with placebo than the really bad psychiatrist was with the active ingredient, the active medication. And it's just like all of what you're talking about is when we try to remove the doctor, the nurse, the social worker, the people from the delivery of healthcare, we're actually removing the treatment. We're diminishing the treatment. What do you think about
Yeah, I
that?
think that's 100% right. I see that in what a lot of people, like people talk about the healthcare industry being run by big pharma and all of us just wanting to write prescriptions and pills. But it also is what people expect from us. When people are sick, they want to go in, get a pill, and be better by tomorrow. And it's like, that's just not reality. That's not how this works. And that's not life. And we don't have that. And then people get frustrated when that's not the situation. But, they usually have other stuff going on in life, and it's just not, this is not the moment for me to be dealing with this, which is difficult. It's hard because I think this is the conversation we're having across the country is like a lot of corporations and hospitals move that way. It's very like cut and dry. This has been shown to be effective, therefore we'll put money into that. And there's so much that is the kind of the gray that creates the quality of healthcare, which does make a huge difference.
I really appreciate you coming on the show. I think it's incredible. I thank Dr. Jon Violetta for being our guest as we get this started and kick-started, and just wanted to wrap up this conversation with AcroPsych and see you on the next one.
Thank you for having me.
Thank you for listening to this episode of Conversations with AcroPsych. I'm your host, Dr. Matt Campbell, and I specialize in psychiatry and addictions. If you have questions about psychiatry or addictions, I host a regular Q&A for therapists, providers, and the general public. You can find more information about us at www.acropsych.com or on all major social media platforms at AcroPsych. We kindly ask you to subscribe to this channel on YouTube or rate us 5 stars on Spotify, since it helps expand our reach and inspire more of our audience.
This episode and all material is purely for general education and not personal medical advice. It does not establish a doctor-patient relationship, and we recommend you working with the appropriate physician or other healthcare provider before applying it to your situation.